Welcome to Module 1, Innovations Aimed at Facilitating Near Uninterrupted HIV Service Access and Utilization. We will be discussing collateral systems, resource mobilization, differentiated service delivery, comprehensive case management, development of case manager cadre, and return to treatment. The target audience for this training module is both health professionals and communities. The information contained in this module is designed for those providing HIV care, including physicians, nurses, pharmacists, and community healthcare workers, and for communities of people living with and affected by HIV. Learning objectives. 1. Describe collateral systems and resource mobilization in the context of the COVID-19 pandemic. 2. Explain PEPFAR's COP 2021 principles of differentiated service delivery, comprehensive case management, and return to treatment. After completing this training, you will be able to describe what is meant by collateral mortality and how the pandemic impacted global HIV services. List the key components of PEPFAR's strategy to mitigate interruptions to HIV services. Explain PEPFAR's strategy to maximize return to HIV treatment. Let's start by reviewing collateral systems. The 4 key implementation themes in PEPFAR's COP 21 guidance are client-centered services, community engagement, resilient and adaptive approaches, and support for sustainable capacity. What do we mean by collateral mortality? We know that natural disasters like earthquakes, hurricanes, tsunamis, tornadoes, and floods bring to mind images of toppled buildings and impassable streets. But in the aftermath of natural disasters also comes the unseen and seldom discussed collateral mortality which accompanies such emergencies. The loss of continuity in care for those living with HIV has individual consequences, but also severe ramifications in the battle against the HIV epidemic. Efforts to achieve universal access to HIV prevention care and treatment can only succeed if HIV programming is included in emergency preparedness plans, something that usually does not happen. The COVID-19 pandemic and outbreaks of other deadly diseases, such as Ebola, has taught us just how severely HIV service delivery can be impacted. Key elements of HIV care preparedness plans include the following: contingency planning to ensure continued supply and access to antiretroviral medications, access to food assistance if needed for people on antiretroviral therapy, uninterrupted access to condoms, continuation and reinforcement of anti-stigma campaigns, and learning from the past which HIV services were most impacted. In the context of the COVID-19 pandemic, viral load testing and new ART initiations were among the most impacted services. In a study from 65 primary care clinics in KwaZulu-Natal, South Africa, COVID-19 lockdowns were associated with a 47.6% decrease in HIV testing and a 46.2% decrease in ART initiations. However, there was no marked change in the number of ART collection visits. ART provision was generally maintained during lockdowns, but HIV testing and ART initiations were heavily impacted. Strategies to improve testing and initiation were implemented. There is evidence that the impact on HIV treatment services was less severe than feared. Here we see trends in people on ART across 5 African countries. The number on ART for the lockdown months of February through July of 2020 did not change much, if at all, compared to the pre-lockdown month of January. In terms of resource mobilization, the Global Fund and partners quickly established access to the COVID-19 Tools Accelerator, which is a global collaboration to accelerate access to development, production, and equitable access to new COVID-19 diagnostics, therapeutics, and vaccines. There was an initial investment of $1 billion with an ongoing need for another $5 billion to continue to battle COVID-19 by protecting both healthcare workers and systems for health to maintain progress against HIV, TB, and malaria. Another example of resource mobilization is the COVAX facility, under which WHO, UNICEF, and partners have distributed free COVID-19 vaccines to 114 countries around the world. Returning to PEPFAR's key implementation themes, front and center is differentiated service delivery, supporting client-centered services and community engagement. We all know what we mean by differentiated service delivery, or DSD. It is the client-centered approach to HIV care and treatment which tailors services to different groups of people living with HIV and their specific needs. DSD may also include decentralized drug distribution through alternative pickup points in communities, such as community pharmacies and community-based organizations. Home delivery is often supported by CBOs and automated systems such as smart lockers or pharmacy dispensing units. Differentiated service delivery models tailor HIV treatment by location, provider cadre, frequency of visits, and package of services, and can be adapted to subpopulations that have specific needs. These models reduce congestion at treatment facilities and have been shown to improve patient retention and viral load suppression. They also enable program staff to spend less time and resources on clients who are doing well on treatment and allocate more time and resources to clients in need of greater support. Visit spacing, multi-month dispensing, and decentralized drug distribution are interventions that have been accelerated during the COVID-19 pandemic. There are 5 ways in which differentiated service delivery for HIV treatment has been accelerated during COVID-19 in terms of policy and implementation. These include 1. Expanded eligibility for DSD, which reduces time on ART before becoming eligible for DSD. 2. Reduced frequency of clinical consultations. 3. Extended multi-month dispensing. 4. Integration of other medications. And 5, community-based models and decentralized drug distribution. Accelerated DSD should continue after the pandemic. We need to ensure that policies implemented in response to COVID-19 become the new normal. 6-month dispensing is preferred, but there may be circumstances when 3-month dispensing is necessary, such as in disruption of ARV supply chains. At a minimum, most clients at ART treatment sites should be offered prescriptions for 6 months of ART, and a fast-track refill model at the site should be adopted. Differentiated service delivery models for HIV often exclude children and adolescents. Alignment of children's clinic visits with their caregivers' appointments, including the location and date of the visit, should be strongly encouraged. Implementing a family-based differentiated service delivery model fosters continuity of treatment for both caregivers and children. Looking at the treatment cascade, we find that men are less likely to be diagnosed with HIV and are diagnosed later. Women are more likely to link to care and initiate ART, while men are less likely to achieve virological suppression. Men are more likely to interrupt treatment and have a higher mortality than women. However, data from PEPFAR suggest that 95% of men returned to care with the support of a man living with HIV serving as a coach or linkage facilitator. Here are some examples of DSD for men. Early morning ART refills at clinics in Zambia and Eswatini, which provide recipients of care with the option to receive screening and medication before the morning rush. This model enables greater privacy for men who face discrimination or stigma when accessing services. Workplace HIV testing in Eswatini, which reduces barriers by enabling men to conveniently access services. Another example, and some quotes from a man who has dedicated his time to bringing men into care. I know that men don't like to come to the clinic because they hate spending hours sitting in the queues, but most importantly, they don't feel comfortable with being attended to by a female health worker. Don't worry, my brother. Come with me to my office, and I can help to fast-track you so that you don't spend hours here waiting to be seen by the nurse. Let's turn now to another new PEPFAR 2021 priority, comprehensive case management. Rapid ART initiation within 7 days of testing positive, but ideally on the same day, results in improved outcomes across the HIV treatment cascade, including greater ART adherence and viral suppression. Rapid ART initiation for key populations should be offered at various points of entry, meeting the client where they can best be served, including at community testing sites, drop-in centers, STI clinics, private clinics, primary care clinics, and hospitals. Comprehensive case management teams should support rapid ART initiation for newly diagnosed key populations members and key populations living with HIV who have been lost to follow-up. Comprehensive case management teams can be composed of HIV counselors, peer navigators, mental health providers, clinicians, and monitoring and evaluation staff. Many of these should ideally be key populations living with HIV themselves. In settings where KP members are newly diagnosed with HIV in a community setting, an integrated case management approach can facilitate linkage from the community to public health systems for rapid ART initiation and continuity of care, or to a KP community clinic. Differentiated key populations case management is important to ensure a people-centered approach. Some clients require a more intensive package of services than others. These can also be progressive, where an unstable client enters the program with intensive needs, stabilizes, and later, after ensuring viral suppression, needs less care. Key components of case management include the following. Frequent personalized support and counseling from the time the client enters the program until sustained viral suppression is achieved. Integrated data sharing between facility and community partners is fundamental to scaling up a case management approach. Regular communication with the client and check-ins with their peer navigator or healthcare team can help identify missed appointments. Their check-ins could be online and less frequently in person, with the need for event-driven reminders, such as reminders for viral load testing. For ART clients facing barriers to regular clinical care and ART adherence, such as homelessness, substance abuse, complaints of mistreatment at clinics, and for those who have fallen out of care previously, continuation of case management is recommended. In Namibia, many key populations will be supported across 73 sites using peer navigation, assisted by an online case management system. Zimbabwe is defining models of services for key populations living with HIV based on intensive or maintenance models to support the sustainability of KP programs nationally. What about the cost? A study of a case management system in 3 provinces in Mozambique reported that the case management cost per beneficiary between enrollment and graduation averaged $4.67 USD per client. Finally, we will look briefly at continuity of treatment and return to treatment, the new terminology from PEPFAR. PEPFAR's 5 core elements for advancing continuity of ART are 1. Commitment by stakeholders to client-centered approaches. 2. Implementation of minimum program requirements related to linkage and continuity of treatment at all sites. 3. Implementation of evidence-based site-level minimum standards for continuous ART as part of a client-centered service environment. 4. Specific customized interventions to improve continuity and return to treatment after interruption designed around specifically addressing challenges noted by current clients and clients' return to care, opportunities and assets specific to the OU and COP21 guidance for all PEPFAR countries. 5. Implementation of quality management policies and practices to support and maintain site standards. PEPFAR makes the point that simply finding and returning clients to the same site if issues persist will result in losing the client again, and that site-specific issues must be addressed. COP21 also includes a recommendation that site performance evaluations must include specific goals for continuous treatment. Return to treatment of clients whose treatment has been interrupted is a high priority for all treatment sites and requires coordinated facility and community efforts. Consistent, affirmative, welcome back messaging that avoids negative consequences of interruption of care and provides positive reinforcement for re-engagement is also a priority for PEPFAR. Continuity of care after treatment interruption should be tailored to individual clients. Re-engagement service delivery algorithms should be developed which clearly set out an expected timeline to access MMD and DSD models. For example, if the issue is distance to the clinic, a client should be supported with 6-month appointments and 6 months of medication with routine phone follow-up. This may also apply to clients living in crisis areas with limited access to care facilities or other displaced clients. Access to MMD of medications should not require clients to prove they are taking their meds. Please take a moment to review this sample algorithm for tracking and tracing clients who missed scheduled appointments. Please take a moment to reflect on these questions related to what you have just seen in the presentation. Had you heard of collateral mortality in the context of health before, and what do you think of the concept? Do you think it's helpful for your work? Did you learn anything new from the section on differentiated service delivery? If yes, what was new for you? Was the section on comprehensive case management useful in your day-to-day clinical practice? If yes, how so? What are your thoughts on the section on continuity of treatment and return to treatment?